Hello, welcome to Chapter 10 on eating disorders. In this chapter, we're going to go through the eating disorders that are in the DSM-5, and as always, discuss etiology and treatment. And then, although not specifically a disorder of itself, we are going to address obesity. And as we're going to see with all of these disorders, they're really not about hunger and eating. So even though obesity is not a DSM disorder, there are definitely psychological reasons, social reasons, sociocultural reasons for obesity. So we're going to be doing the same multi-path model to try to explain the obesity epidemic. So in this chapter, eating disorders are disturbances in eating behavior that result in the person eating too little or eating too much. And there are 3 disorders in this section of the DSM-5, anorexia nervosa. And we're going to see there are different subtypes of anorexia nervosa, bulimia nervosa, and binge eating disorder. So even in non-diagnosed individuals, concern with our weight is prevalent in our society, starting at a very young age. So you have this chart in your book that just shows you the percentage of both young people of both genders who express concern about their weight, have been on a diet. Parents have commented about their weight and suggested a diet, and even engaged in binging and purging behaviors. So this is a summary of the disorders we're going to be talking about in this chapter. So again, you have this in your textbook in this section to help you get an overall picture of the 3 disorders. And there's some overlap, so it's very important you're able to make the appropriate distinction between these eating disorders. As we're going to see, these disordered behavior of eating is often accompanied by some other mental health issues that we have discussed already and that we will be discussing in chapters to come. So depression, substance abuse, suicidal ideation. And we're going to see that there's a lot of unhealthy things in our society that really seem to contribute to eating disorders. So even though we have this overall societal emphasis on thinness that can cause people to have distorted body images, nonetheless, we are still an obese population overall. As of 2012 data cited in this chapter, 68% of adults were overweight. So let's start with anorexia nervosa. In anorexia nervosa, the main symptom is restriction of food that leads to significantly low body weight. And even though their body weight is getting incredibly low, and by all objective standards, they might look skeletal, these individuals will still have an intense fear of weight gain and still perceive themselves as fat, even if they are emaciated. A main way of figuring out what is too low of a body weight is the BMI, the body mass index. So it's not just the number of pounds that is the best indicator of whether or not you are overweight. It is taking into consideration your overall size, your height as well. So in the DSM-5, an body mass index less than 18.5 is a diagnostic indicator of anorexia nervosa. So you have this chart in your textbook that gives us the body mass index, and if you've gone into the doctor for a physical or whatever, you've probably been told your body mass index, and we want to hope that it is within this blue range here, which is an indicator of a healthy body mass index. When we get below that 18 mark, then this is an indicator of anorexia. And we're going to see that many of us, by the health standards, are overweight by our body mass index. So once you get past that 24, you're out of the healthy range and you are into the overweight range. So anorexia obviously is characterized by extreme thinness. You will see the bones, the ribs. These people will primarily adolescent girls and young women. We're going to see, though, anorexia can affect males, but is primarily found in females. And they will not eat. They will literally starve themselves and continue to lose weight to deadly levels. They literally sometimes will starve themselves to death. Now, in the DSM-5, anorexia nervosa has a couple of subtypes, and this can make things challenging when we talk about the next disorder, bulimia nervosa, because there are some symptoms in common. So the restricting subtype of anorexia nervosa is the person is losing weight through severe dieting and often excessive exercising when they can. Once you lose so much weight, you don't even have the energy to move sometimes. In terms of other associated factors and personality types, these people tend to be more on the introverted side. So we've talked about personality types before. You've learned the big 5 in intro psych, and extroversion is one of the well-studied big 5 personality traits. So people with the restricting subtype of anorexia nervosa tend to be low on that extroversion. Then there's the binge eating and purging subtype. Now here is where it gets challenging, because we're going to see this is what the next disorder we're going to talk about is all about, bulimia nervosa. So in the binge eating purging subtype, there will be episodes of the person overeating, but then typically engaging in some compensatory behavior, usually self-induced vomiting, but sometimes abuse of laxatives to get out all of the food. In terms of their personality subtypes, they tend to be higher on the extroversion scale, but more impulsive. They also report more anxiety and depression. Now, to keep it straight in your head, what's the difference between this and bulimia nervosa is that in anorexia, that severe weight loss is the key indicator. When we get to bulimia, we're going to see not all people with bulimia nervosa have abnormal body weight. In fact, some are within the normal range, but they're maintaining it in a normal range in a very, very unhealthy and dangerous way. So in your application assignment, you have a case study of a young lady named Lynn, and you are asked to figure out what would her diagnosis be, what do we know about etiology. So what can you pick out from this case study that would point you to an appropriate diagnosis? And in fact, you can even have a specific subtype when you identify this one. So I want you to tell me why you went with that subtype. And then shortly, we are going to talk about etiology and treatment. So those are things you're going to need to address in answering this case study. So one way to help with making that differential diagnosis is, as you know from way back in the beginning, I think it might have been chapter 3 when we talked about how do we make these diagnoses, and we talked about things in a typical psychological evaluation. So if we're investigating for an eating disorder, one good addition to that psychological evaluation would be an eating disorders inventory that asks questions specifically about the different symptoms of the eating disorders that would allow us to sort out the various symptoms and make the appropriate diagnosis. So this is, again, from your textbook, just a sample of some of the things on the eating disorders inventory. I believe this is from your textbook. Maybe I got it from another source. I don't know. We also have to assess the person's body image. And one thing that we have to note is that, again, because of things present in our society, even non-diagnosable women tend to have distorted body images. So this is just a side-by-side comparison of the body images of women who scored high on an eating disorders inventory, like we just talked about, versus ones who scored low. So they asked the women, what kind of body image do you think would be attractive? What do you think is your ideal body image? What do you think other people consider attractive? And you're going to see even those who scored low still had the same kind of pattern, but those who scored high on the distorted attitudes toward eating was even greater. So here's where they really are, but way down here is what they think would be their ideal. You know, they say this is what they think would be attractive, and this is what they think other people would find attractive. Well, notice even in the non-eating disordered population, they still think the ideal is quite a bit below where they currently are. And they still have that distorted perception about what really is attractive and what other people find attractive. And we already discussed all of this. All right, so compared to some of the disorders we've talked about thus far, anorexia nervosa has a little bit of an earlier onset, typically occurring in early to middle teens. Again, is more likely to be occurring with young girls. It's 10 times more likely to occur in women than in men. But when it does occur with men, the symptoms are the same. Um, it's typically triggered by dieting, and then the person just can't seem to stop and it goes too far. So dieting and stress tend to be triggering events. It is a disorder that has a relatively low prevalence, a lifetime prevalence of less than 1%. There's a lot of comorbidities with anorexia nervosa. It is a very sick and dangerous disorder. Can be comorbid with depression and panic disorder and phobias and OCD and alcoholism and personality disorders. When it does occur in men, it's more likely to be co-occurring with the substance dependence and mood disorders or schizophrenia. There is a very high rate of suicide in anorexia, with 20% of people diagnosed with anorexia nervosa attempting, and then 5% actually completing. And beyond that, beyond the risk of suicide, it's just very deadly because of what the person is doing to their body. Some literally die because they are starving themselves to death. So you have a couple of unique videos in this chapter. Although we associate eating disorders with women, they can occur in men. And you have a link here to one such video of a man with anorexia nervosa. Again, the symptom manifestation are all the same. So pause me and take a look at that video of a case study of anorexia nervosa. Now, there are lots of risks to your body when you are literally starving yourself. And again, it can be a death sentence for some people with anorexia because the blood pressure drops low. Your heart rate decreases. You will have problems with your kidneys. Once you've exhausted your body of all the nutrition, and you have to exert activity to keep yourself alive, that comes from your muscles, and your muscles start atrophying, and your heart is a muscle, so you can have heart damage from anorexia nervosa. When you don't get enough nutrition, you're going to lose bone mass. Your hair and nails are going to look awful and become brittle. Women often develop what's called lanugo, very soft, downy body hair, sort of like the kind that you might see in a newborn baby. Literally, many of these, again, usually women who are not eating, are depleting themselves of necessary electrolytes even to keep themselves alive. So at a certain point, they are tired, they are weak, and some literally die. There's a whole range of other health risks when the person is engaging in that self-induced vomiting as well. And we're going to cover those in more detail when we talk about bulimia nervosa. It is also a disorder that can be incredibly long to treat. If we can get a person into treatment, 50 to 70% will eventually recover, but it may take 6 or 7 years with a number of relapses in between. So although that sounds like a decent number, that means 50 to 30% are not recovering and maybe dying. The death rate in anorexia is 10 times higher than the general population and twice as high as any other psychological disorder. We might be able to psychologically modify the behavior of the person with anorexia, but psychotherapy can't do anything about the culture that has ingrained in us, this idea about valuing thinness. In terms of recovery and the progression of the disorder, it is highly variable from individual to individual. And things that are associated with less favorable outcomes are when you have more comorbid conditions like obsessive compulsive eating behavior, or that purging, binging and purging subtype. In addition to all the things we have discussed, people with anorexia nervosa are going to experience depression, anxiety, impulse control problems, and those impulse control problems can manifest in other kinds of impulse control disorders like substance use. Ironically, although many people are focused on the thinness because of, associating thinness with sexiness, you lose your sexual interest when you are that thin and weak in anorexia nervosa. All right, so the next disorder we're going to talk about is bulimia nervosa. In bulimia nervosa, the criteria involve episodes of binge eating. Binge eating is defined as eating enormous amounts of food in under 2 hours. And when somebody is engaged in a binge, they often will report afterwards that they lost control. They didn't even realize how much or how fast they were eating. It's typically high-fat junk food that they're binging on, and they will continue to eat long after they are full. And then after these episodes of out-of-control eating, then the next criteria for bulimia nervosa is engaging in compensatory behaviors, something to make up for the binge. And the most common is purging, self-induced vomiting. But other people will use diuretics, laxatives, then follow it up with excessive exercise and fasting. But the purging is the most common one. And for bulimia nervosa, severity ratings are based on the number of times that the person has engaged in the compensatory behaviors per week. We're going to see a video case study shortly where the person reports vomiting, 6 to 7 times per day. So that's pretty severe if you're doing that number of times per day. So in your application assignment, you have a case study of Jill. So go through that, determine the diagnosis, including the severity specifier if you feel you have enough data there, and tell me why. Why did you pick out the disorder that you did? And then use the multipath model to talk about etiology, which we're going to cover shortly, and then talk about proven treatments. So what triggers a binge? Well, many people, again, even non-disordered individuals, will eat at times when they're not hungry because of stress, because of negative emotions. So when somebody with bulimia experiences those things, they will have a binge. And again, it's typically these high calorie junk foods. And people with bulimia nervosa report that if they recognize this as a bad food and that they should avoid it. But if they avoid it and they're craving it, then when they experience a binge, that's likely the food they're going to go to. People who have eating binges are not shoveling this food into their face in front of people. They are conducting it in secret. They often report just losing track of how much they're eating and time, almost like a dissociative experience. And then when they're done, they just feel disgusted with themselves. They regret doing it. And then that extreme guilt or shame is what then provokes the need to purge. Now, people who have bulimia nervosa, they recognize that this is not normal, but again, they don't seem able to stop themselves. This is a disorder that is more prevalent than anorexia. You will see in the DSM criteria for bulimia nervosa, it says nothing about your body weight. Because that is not a diagnostic criteria. The diagnostic criteria are based on these episodes of binging and purging. So we said anorexia nervosa was less than 1% of a lifetime prevalence. This one's about 2.6% of women. And out of all the people with bulimia nervosa, 10% are male. Now, we have another case study of a male patient here with bulimia nervosa. So I encourage you to pause me and take a look at that video. Again, the symptoms are the same. So as a recap, what is the difference between bulimia and anorexia, particularly that anorexia binge eating purging subtype? Well, again, the main difference is the weight. The person with anorexia who's engaging in binging and purging is losing weight. Their weight is way below normal. Whereas somebody with bulimia engaging in binging and purging, their weight could be normal or above normal. But again, it's not a healthy way of maintaining a normal weight. And we're going to see all of the risks with that constant binging and purging. So again, in your application assignment, you have the question of, you went through 2 case studies and they had some similarities, but you gave them different diagnoses. Why did you do that? What specifically are the determining factors that's going to differentiate bulimia from the binging purging subtype of anorexia? Now let's look at some of the associated features. So again, it's still more prevalent in women. 90% of people with bulimia nervosa are women. The age of onset is a little later, typically in late adolescence or early adulthood. People with bulimia nervosa, as you saw in the case study video, typically started out as overweight, and then that led to some dieting, and then you can't keep up the diet because you've deprived yourself, so then you binge, and then you feel guilty about the binge, so then you purge. Again, there's a number of comorbidities with bulimia nervosa, including depression, panic disorder, anxiety disorders, substance abuse, but also some externalizing disorders like conduct disorders. Suicide is also a risk. It's higher than the general population, but lower than the risk in people with anorexia nervosa. And again, a distinguishing factor is that when we look at the body mass index, people with bulimia nervosa often have normal BMIs. But again, it is not a healthy way to maintain that normal BMI. There are a number of health problems and physical problems that are associated with bulimia nervosa. So for women, you might stop having your menstrual cycle, or at least it's going to be irregular. One of the reasons being is because when you purge, you are depleting yourself of necessary electrolytes. Think of a time when you were really sick. I know it's happened to me a few times where I got a stomach bug and I started throwing up and I got dehydrated. I ended up having to go to the ER to just get an IV to replenish my electrolytes. That person with bulimia might intentionally be doing this to themselves. Again, 6 times a day. Think of a time you got sick and you threw up and how it felt. It often burns your mouth, your nose, because you're throwing up that stomach acid. If you're doing that 6, 7 times a day, that stomach acid is going to burn away the enamel on your teeth. It's going to cause sores in your mouth. All of that sticking your fingers down your throat, you'll often end up with, sores on your hand that are called Russell's signs. It's a good diagnostic thing to look for, when you're doing a clinical evaluation. So this is deadly. All of that constant purging is deadly. There's a mortality rate of 4%. So again, even if they're not intentionally, attempting suicide, they're still putting their lives at risk. Here is just a nice summary chart of how all of the areas of your body can be affected because of this constant binging and purging. So again, all that stomach acid tearing up your mouth, your throat, your esophagus. Think of a time when you were sick and you were really heaving. That hurts your diaphragm. That puts a strain on your heart. It changes your blood pressure when you're doing all of that constant heaving and throwing up. So it's affecting you in many, many areas of your body. The prognosis is better than for anorexia, but again, these are both tough disorders to get over and treat. About a third are going to get better and be in complete remission. A third are going to be in partial remission, and then a third are going to continue to meet the diagnostic criteria for bulimia. The earlier we can intervene, the better it is. And if there's any of those comorbid conditions, or they're at the severe ratings of bulimia because of the number of purges they do per week, we have a poor prognosis. So the third disorder in the DSM-5 section on eating disorders is new to the DSM-5, and it is binge eating disorder. So we talked about what binge eating is when we were talking about the symptoms of bulimia. In binge eating disorder, that's where it stops. So the person is going to have these recurrent episodes of binge eating where they're eating a lot in a short amount of time until they're uncomfortably full, even when they're not hungry. They're doing it alone and in secret. They will still feel disgusted and depressed after they've done it, but then that's where it stops. They do not engage in the compensatory behaviors. So the severity ratings for binge eating disorder are based on the number of binges that they have per week. So again, let's look at comparing it to the other eating disorders. So again, in binge eating disorder, they're certainly not losing weight because they're having these episodes where they're eating incredible amounts of food in a short amount of time, and then they're not doing anything to compensate for it afterwards. So that's what distinguishes it from the other eating disorders. So in your application assignment, you've got the case study for Amy. So again, read that case study. What eating disorder diagnosis do you think she meets criteria for, and what specifically did you pick out from that description that pointed to that diagnosis? Likewise, can you talk about a severity rating and why? And then what's the etiology using the multipath model and treatment, which we're going to be covering shortly. So people who have binge eating disorder typically are obese. So they have a body mass index of greater than 30. Now it doesn't work the other way around. Every obese person does not necessarily have binge eating disorder, but about, a certain percentage, and it's sort of unclear, 2 to 25% of people who are obese may qualify for a diagnosis of binge eating disorder. And typically, risk factors are these people have been overweight, probably since early childhood, and have been taunted about their weight. They have low self-concept and depression. Also with people with binge eating disorder, an increased likelihood of having experienced physical or sexual abuse. So again, the disorder is not really about eating. They've had some terrible things happen to them. They've got some awful emotions within them, and their coping mechanism is to use food in a very unhealthy way. Lifetime prevalence, about 3.5% of women, 2% of men. When we look at those who actually come in for treatment, it is mostly white women. But when we look at the percentages of African American and white women who have binge eating disorder, they're roughly equal. But again, this is something that is probably reflective of larger systemic things that also find their way into psychological treatment where minorities are not getting access to the kind of treatment that they need. So associated factors, again, likely to have been overweight. 20 to 40% were in some kind of weight control programs. And again, the typical kind of thing that might provoke a non-disordered person to want a snack or eat when they're not hungry are occurring for people with binge eating disorder. So, a bad mood, just not feeling out of control, feeling cravings, those kind of things tend to precede a binge. Now we are going to talk about obesity shortly, and a lot of the physical changes and risks that occur with binge eating disorder are also found in people who are just obese also. So increased risk of type 2 diabetes, cardiovascular disease, breathing problems. All of that extra weight puts extra strain on your joints, so more physical ailments. But there are problems associated with binge eating disorder that are sort of independent of just being obese. And those include sleep problems, the comorbid psychological conditions like anxiety and depression, irritable bowel syndrome because of all of that, rapid eating, and a girl's period tends to be associated with her body fat. So the more body fat, the earlier menstruation occurs in these women, which is not always a good thing since women have a limited number of eggs in a certain period in their lives when they are fertile. So if you start early, then that means you might end early and not be able to bear children later in life when maybe these women might really want to. This is a disorder that, like bulimia nervosa, begins in late adolescence or early adulthood. Much higher remission rates than the other eating disorders. Again, a very, very long one to treat. On average, it is lasting more than 14 years before a person is able to get over it. And even if we can get the binge episodes to stop, these individuals still tend to be overweight even after. Again, recovery rates vary greatly depending on the study. It's estimated at about 60% will recover. Now, there are some things talked about that are still disturbances in eating behavior that don't necessarily meet criteria for either anorexia nervosa or bulimia nervosa. So night eating syndrome, people who seem to meet a lot of the other criteria for anorexia, like that extreme distorted body image, that extreme concern about their weight, yet they're not, of the low BMI, their weight is normal. There's also individuals who seem to meet the criteria for bulimia, but their binging episodes are not as frequent, below the diagnostic criteria, so less than once a week. And likewise, people who are purging without necessarily experiencing the binge first.